Happy New Year, everyone. This is our first seminar of the new year, and we're going to have a seminar from one of our own, Dr. Geoffrey Bove. Jeff is a native Bana, grew up in Saco and Kennebunkport, and still lives in Kennebunkport. But then he went away to First Hampshire College, where he raided Amherst College for his wife. And then both of them went on to the Canadian Memorial Chiropractic College, where he graduated in 1998. Then he went to get his degree in anatomy and neurobiology at the University of North Carolina, and has had a number of different appointments, both in Boston and then came up to Maine. And you don't say what year you came up here, but it's been a while since you've been up here. He's a professor in the Department of Biomedical Sciences in the College of Osteopathic Medicine, and his seminar today is Clinical Relevance of Ectopic Axonal Sensitivity.
Thank you. Yeah, I made a boo-boo there. We were just talking about journalistic mistakes in an article that we were looking at, and it says 1998. That was 1988. I'm not that young.
Oh, 88 and
yeah.
94. Okay.
And I never lived in Saco.
Oh, you never lived in Saco?
No offense.
Okay.
So anyway, thank you for the introduction, and thank you for coming. How many med students are here? Yay! Thank you for coming. This is not a translatable talk. This will be a already translated talk. So the clinicians who practice manual therapy and those of you who will or diagnose anything that has to do with radiating pain should be able to take this with you for your practice for the rest of your career, actually. Now, I always feel like telling people some kind of reason why my presentation might be a little choppy. I don't consider myself very good at these, so I like to make excuses, but of course I can't. Now, this time I have a real excuse. How many of you went to my father's talk last year? Really? Okay, so that was all. My father has pretty much the worst kind of chronic pain you can have, and it's extremely ironic that I study neuropathic pain and chronic pain, and so there's nothing I can do. And that's amazingly frustrating. Over the last week, it's come to a head to the point where I've been on the phone yesterday for close to 3 hours with a industry attorney, a private attorney, Dartmouth's attorney, the doctor, and the representative from the, and we don't want any lawsuit or anything, but there's been some serious things gone awry, and I'm going to tell you a little bit about his case because it is relevant to our pain field, and we all, most of us study, a lot of us faculty study pain. So anyway, back in 2003, he had, I don't know if it was reactive or primary, but he had a psoas major muscle strain. This is the muscle that primarily flexes your hip from a lot of bicycle riding, and he was working out at the gym almost daily and swimming almost a half mile a day, and he was 83, 82, 83, 84. He just had to remember his birth year. And he went to the hospital with severe pain, and he was not diagnosed with shingles. He kind of wasn't diagnosed, but they saw what looked like a aortic aneurysm in his lumbar area, and he went to Maine Med, and they found a small aneurysm. It was stable. He was pretty freaked out by the whole thing. And anyway, then he went back, that was in like June or July, he went back and got a diagnosis of shingles without any rash, which is not the way it usually develops. It was an osteopathic physician at Southern Maine Medical. And then slightly thereafter, he developed this classic rash associated with T12 and L1. His physician had never given him or offered a shingles vaccine, which is the first mistake. And everyone who's cared for him in the last few years has been extremely well-meaning, but they haven't been informed about. That's why I'm actually telling you this is a case of the clinical field, not understanding how pain works, not knowing the basic neurobiology of pain, and that's a challenge that we all have, is to help educate clinicians, and there's big efforts to that. So this is a year later when he wasn't responding to anything. And this is his posterior superior iliac spine and anterior superior iliac spine. So it's here and here on the left. And I took a probe from a 1 millimeter syringe, the plunger, and I poked around it, this whole area, and I mapped out where he's most sensitive. And that's where he was most sensitive. And this is after a physician, his primary care person, did what is loosely considered and very unscientific, did a trigger point injection. I'll throw the trigger points up in air quotes and direct you to a paper on trigger points, the fallacies associated with trigger points that we published about 2 years ago. And what had happened is the injection had damaged one of his cluneal nerves, which is a sensory nerve innervating the skin over here. And he didn't have postherpetic neuralgia, that had subsided, and now he had this band of neuropathic pain coming around to the midline, classic neuropathic allodynia. I imaged this with a clinical ultrasound, and what you're looking at here is consistent with a neuroma. And this is about 1.5 to 1.7 centimeters deep. So that was directly under here. I sent him to a physician I know from the pain clinic at Beth Israel, who I trust. He did a spinal nerve block on T11 and T12 and L1. It made this pain regress, came back in 4 hours, and that was it. So I took measures into my own hands, and I guided a hypodermic syringe in here with, at that time, very old Marcaine, and it made everything disappear for 4 or 5 hours. And I called the pain guy, and he said, do it 4 or 5 more times. If it keeps working, then have him come down. I'll do a cryoneurolysis, which we did. But you know what happens when you start cutting nerves or damaging nerves? Now, I was trusting him because science and clinic don't necessarily go hand in hand. Cryoneurolysis is one of our pain models. Anyway, it made it worse, and after that, it didn't respond to local injection anymore. Fast forwarding to, he had then, after various treatments, actually in the beginning of 2016, he had a surgery in the allodynic area for a hernia repair, and the physician didn't remove his anticoagulants that he was on, and he almost bled out. He ended up with 100% kidney failure in intensive care for over a week, getting blood transfusions and getting his kidneys back. So since before this, he also then had a implant of a neuromodulator device that just came on the market last March. I had done some early I tried to do some early characterization of this device in about 5 or 6 years ago, and my problem was that I couldn't get the device to function. I was supposed to test it on primary afferent neurons, the cell bodies. And since then, one of my colleagues actually has tested it and just published a paper, which I reviewed quite favorably, even though it didn't work for my dad. So after that was implanted in September and October, and this I can tell by the wounds, this is where they implanted leads into his intervertebral foramina right on the dorsoroot ganglion, extradural on the dorsoroot ganglion here. And then this is where they implanted the battery and the cord. At that point, it wasn't even working anymore. But that's only, I can't go into too much detail on this. So at this point, he's had them reposition the leads once. This is a while after the surgery. You can see the staples are out. But I mapped out his pain level. I mean, his pain areas. That's not better. Then he had the leads repositioned, and then I mapped out his allodynia. And for a while, it was up into his cervical spine, and it was extending down his back. And also by now, they poked around at L2, the second lumbar dorsoroot ganglion, and he lost the ability to flex his hip. Now, he has a clutch in his car, so he drives without the clutch, which is pretty cool. But he has to lift his leg up. And he doesn't want me to get him another car. So anyway, that subsided a little. On the 23rd of December, they decided to remove it. And I noticed he was saying his leg hurted. I can't. This is chronic regional pain syndrome. And this is the nice job they did on his back. They had to lean against that. So just keep in mind that people suffer a lot. And that you don't want to do mistakes like this if you can help it. And this is the only thing he says helps. That's my spouse. Okay, on to the, sorry about that. I knew this would happen. Go ahead.
There's a book by Ivan Illich, that's not his real name, that's his writing name, and it's called iatrogenesis. And no matter what you want to do with your life, you don't hurt someone.
That's kind of the golden rule, but, and the doc, see, I've spent like 8 hours this week, so if I go rockier from now on, that's my excuse. How's that? I'm using my dad for my own benefit. But I've spent 8 or 10 hours this week talking to various people, and last night I found out that the physician, he told me that he lied to me about some things. He actually said. And then he told me that after this surgery on the 23rd, he said, it was really late, it was our last one, and we made some bad decisions and mistakes and hurried through and put staples in that we knew were going to hurt him, which I took out the following Monday. But anyway, and I was like, wow, at least he's admitting it, right? So anyway, this is a real pain case, and he's not the only one. And now I'm not hoping that the device is faulty, but I've been in contact with them to find out if the device is faulty. So we need to know whether it's a failed treatment, which happens all the time, right? Because we don't know enough about pain, and you're not throwing darts at a target. You're throwing darts like this, and you with your eyes shut in a blindfold, just using whatever you can. Because what else are you going to do? Because patients want it. They'll force you to cut all the way up into the a dorsal column lesion even, and that when it's just making it worse and worse. It's like going to a physician and asking for antibiotics. If the doctor doesn't give you a prescription and you feel like you're sick, patients tend to go to other doctors until they get a prescription. They should have placebos. Should be ethical to give placebo, since a lot of them are working that way. Anyway, we know that too. Okay, so today I'm going to focus for the rest. Sure, that's why we're not going to get to you. On the research that I've had a common thread with some interruptions since graduate school in 1992. And I've looked at the mechanisms of radiating pain. So what's the clinical problem? So radiating pain, what it is when there's a perception of symptoms, in this case pain, like say you feel pain here, but there's nothing wrong here, and they find a problem, or a problem is found more proximally, like for instance a cervical discal herniation irritating a nerve, which I'll go into these examples, and that's responsible for the pain. It's not referred pain. Referred pain is like or a case of anecdote for referred pain is when you see in the media people go, oh, and they're having a heart attack. So that's when afferent barrages from the heart are so strong they go up and they activate other levels from other areas and wide dynamic range neurons and all the complications of the central nervous system, which I don't know very much about, but it's kind of a spillover activation where you feel it in an area where there's no problem. So there's you have to keep clear the difference between referred and radiating pain. Sciatica is the classic example and the most common example of radiating pain. We know the most about that because of, again, disc herniations, which usually aren't the problem. A lot of cases of carpal tunnel syndrome aren't, but even the ones that are carpal tunnels, that actually the carpal tunnel is compromised, and that's the only place that the radiation of the pain is into the hand, and the sensory problems are in the hand. They're so common that, let's count, 16, no, I can't count that fast, but there's 50 people in here. It's likely that somewhere close to a third or more of you will have sciatic type pain, which, by the way, that's a symptom set, it's like neuropathic pain is a symptom set. These aren't diagnoses. They're diagnoses that carry zero etiological specificity. Does anyone here want to say or be willing to say whether they have a radiating pain syndrome or like sitting there with radiating leg pain? Because there's about almost a 100% chance that someone would, although we have a quite young group here.
Right now or ever?
No, something that's active, like a movement-induced or ongoing radiating pain. I know Amy real well, so.
I'm on prednisone, so I don't have anything right now.
I could give you some pain. You do?
I had a sacral torsion, that was basically a radiation of pain from the sacrum being rotated that caused the pain to go down to my leg. And I actually had other symptoms besides that and couldn't even hardly get out of bed and walk. And I was like about an 80-year-old for about a couple of weeks until I got treated.
And you don't have that active right now,
No,
Oh,
obviously, it's not.
though? No, I wanted to do a
Let me ask you something,
demonstration.
Dr. Bove. For the students here in the audience, could you talk a little bit about when you use your words for like referred pain and what's not referred pain and what's sciatica? Since you've been at an osteopathic school for a long time, could you talk a little bit about what that would mean when you talk about somatosomatic response and visceral somatic response or visceral somatic visceral response?
I would love to teach that in the curriculum, and that is not something I'll touch on now, except right at the end. I'll just hint at it, but this is a 3 to 5 hour part of that's something that I should do. That was my initial proposal when I went to graduate school. This is not osteopathy owned. This is a chiropractic osteopathic shared concepts that were developed in the late 18th century. 18th century. I get those confused. In the 1860s to 1890s. 19th century. I have learning disabilities. I'm dyslexic. I can't focus. But I would love to do that. On the other hand, without the knowledge that I'm hopefully going to transmit to you, you won't be able to easily tell the difference between radiating and referred pain. That's actually the translation here. So the point here is, what's the pathology when your person's having radiating pain? Dr. Doan just said she had sacral torsion. Very highly unlikely that sacral torsion was the direct cause of her radiating pain. And I'll bring her up again as we go on. The classic pathology was discal herniations. And I don't know if that was motivated the same way that hysterectomies were motivated, or a number of other things that ended up going by the wayside. This is going a little bit by the wayside, or they're being careful, because we've known for decades that young men that have never had back pain in their late teens and early 20s, almost all of them have disc herniations. So they're not normal, but they occur normally. It's rare to have a disc herniation. The older you get, the more the discs dry out, so they can't herniate. There's other problems potentially associated with that. But still, this is a stat from the 1998, 500,000 surgeries in the United States, and a lot of reoperations. Those reoperations, the rates vary in the literature, and that's because we don't know if those were misdiagnoses because no one was looking at other causes, or whether they were complications or other discs or something. But I've seen a number of patients. Everyone here that treats patients sees failed back surgery a lot. And it's likely, in the cases that I've seen, it's because no one looked at the other sources of potential problems, which would be highlighted here. And I was really happy to see this, as I stole it from the interwebs, where they're looking at sites of inflammation of the peripheral nervous system. That's a dorsal ramus of the spinal nerve. This, they're trying to show the facet joint, but instead they're showing a laminar fracture, which I kind of like that. But mostly, this inflamed nerve, an irritated nerve, is kind of the focus of this. So how would an inflamed or a nerve or a tight muscle or an inflamed muscle cause radiating pain? That's kind of the question I posed in clinic, one of the questions I had in clinic. And that gets to the science that came out of that. So just as general, if this is a left-sided dorsal ganglion neuron in the intervertebral foramen, basically, in the dorsal ganglion, This is the periphery, and this is a nociceptor where I, stab myself here. And the action potentials are transduced here. They run up here, and they go into the dorsal horn, where there's another release of neurotransmitter and a chemical relay of information, which you all know about. That's how they normally work. Ectopic activation is a situation where the axon is modified through pathology to be capable of sending the same signals as from here. So you don't need activation here anymore, even though activation there remains, and I'll show you the basis for this. And then for mostly completeness, this would be a neuropathic activation, where if there's been a nerve injury or something that, a nerve injury meaning the axons have been interrupted, and activation here won't cause anything because the cell stays alive and it tries to regrow, but the periphery is disconnected now. So that degenerates within a week or so in a process called Wallerian degeneration. Then you can stimulate the end of that cut end. Sometimes they form a mass called a neuroma, and that can possibly send. But the majority of injuries like this don't cause any symptomatology except peripheral numbness, especially if they're clean injuries like during a surgery. And I'm feeling here because I yanked up my mooring pennant, which is the boat on the cover of the UNE magazine this month, and last summer, and I pulled it up with a large fish hook going in this side and the barb coming out that side. And when I ripped that thing out, it ripped a branch of my radial nerve here. Felt wonderful, and it's been numb ever since. And we say, oh yeah, after a few days, the axons grow at a rate of 2 or 3 millimeters. I've had other nerve damage. They don't grow. This is not growing back at all. In fact, it's gotten more just numb. No pain, just numb. So we're going to focus on this. This has been the research, if I ever get to it. So I started looking at what I think is happening, which is inflammation affecting nerves and the axons within them, with the nerves being innocent bystanders. So there's nothing really wrong with the nerve. It's just reacting to its environment. And so I didn't design a model. I took a model from Gary Bennett of neuritis, or nerve inflammation, where a blob of gel foam is placed around the nerve with complete Freund's adjuvant, which I always say is like a salad dressing made up of oil, mineral oil, a little vinegar, a little saline, and Mycobacterium tuberculosum as the spices in there, and then it's emulsified. And we place that on the mid-sciatic nerve, and it basically causes what they depicted here. And then we record it in normal and these pathological conditions from individual dorsal ganglion cells that were intact neurons with receptive fields in the skin and the muscle. And this was the kind of the breakthrough set of data that we published in 2003. And you can see that of the deep nociceptor fibers, so these are the ones innervating muscle, tendon, and possibly joint, that we didn't see any specific joint, that a proportion of those, a substantial proportion, developed axonal mechanical sensitivity. But notice that the cutaneous ones didn't, and I'll get to that in a minute. Excuse me? In rats, yeah, this is in rats. Can't do it on humans more than once. So in stark contrast, you can see that under control or non-control situations, nothing. And I know for a fact, because one of the reviewers of this article told me that they had to be extremely careful with this because it was so cut and dry. And usually data that are so cut and dry have something, it raises little red flags. I threw away half the data from these experiments because they were done by a postdoc who I trusted explicitly, but I didn't trust a lot of the recordings, so I just didn't include them. And there's still tons of recordings here. So this is of really big interest to me. If you've seen patients, you know that people don't really complain of superficial pain. They complain of deep pain. But you're taught to test dermatomes, which is if you have denervation, you get spinal levels of dermatomes, or if you have a nerve damage, like an overt nerve damage, you have a dermatomal or on the skin deficit. So I asked that question because no one else had, and I was kind of shocked that no one else had, but this was a publication where we recruited about 25 patients that were proven radiculopathy. So they had a proven disc herniation with a known deformation of spinal nerve, and they had radiating pain, but they didn't want surgery, or they were waiting it out because most of these self-resolve after a year. You can't tell the difference between someone that got surgery or not. Some people just need the surgery so they can get on with their life, depending on their activities. So there was nobody in this study with ongoing pain that they perceived in the skin or radiating pain when we tested them mechanically that they felt in the skin. Not a single one. And I think when it comes down to it, the diagnosis will be taught in the literature that if there's numbness in it or peripheral pain, it's probably coming with nothing peripherally injured. It's probably coming from axons that have been damaged, and it's an end organ neuroma or something, or a neuroma in continuity, which is a bunch of broken axons trying to regrow through a nerve. And that otherwise it's an inflamed nerve, or otherwise not pathological. And I just wanted to point out that after, what was this? This was 14 years ago. I just noticed a typo. Look, that should be 266. Oops. I didn't catch it. The co-authors didn't catch it. The reviewers didn't catch it. That's like right after you hit send on the grant application, you pull it up to look at it. You say, oh, no. Okay, so being from having been taught chiropractic and osteopathic philosophy, like one of the books that is I almost said a core book, but it's on your reading list. It's the editor is Erwin Core, one of the most famous osteopath related basic scientists. And there were these old concepts that we talked about. They used to talk about nerve pressure, which is something a patient can understand. But I think they really thought it, and they talked about an analogy of a garden hose. So you step on a garden hose, you step on a nerve, and it reduces the flow through the nerve. Okay, so let's test this in the lab. So that's not necessarily inflamed, so I stepped on the garden hose with colchicine and vinblastine, which are actually anti-inflammatories. They break up microtubules. This is a very, very low dose and transient, 15 minutes. So it never caused any axonal damage, which it will. And these are vinblastine is a chemotherapeutic agent, which helps. It's not used as much, but a lot of these drugs cause neuropathic. Basically, almost everyone with chemotherapy gets neuropathic pain. A lot of them recover from it, but a lot of them don't too, because they go over the clinic. The dosage is actually the threshold for neuropathic pain, not the effective threshold. So they do combinations to avoid it. And that's a ripe field for research, but that's not what we're doing. So we basically took out the inflammation, and we don't talk about results unless they're exactly what we want, right? But we got both of these agents caused the axonal mechanical sensitivity. And on all these experiments, we know that it's not damaging the axons because we stimulate peripherally. So we go like this and we get a response. This is one that was colchicine, one that was vinblastine. Then we go up and poke on the nerve where we had applied the agent. We get that response. And just to prove that we didn't damage the axon, we go back to the peripheral receptive field. So every single neuron that I'm showing you has had that test performed on it. And this, I think we only got it in Journal of Physiology because Andrew Dilley's British, but those things happen too. So we took advantage of it. So we hypothesize, and still do because we don't have perfect proof, that these treatments the treatments that cause axonal mechanical sensitivity cause it by reducing the axonal transport of the mechanosensitive channels.
Are you going to talk a little bit about the timing here? Because I'm wondering, how long do you have to put it
Oh, yes, thank you. See, I'm running over already.
How long does and how long does
Thank you, and thank you. It's all in the papers.
Yeah.
These are, okay, so this is a couple years' work, tedious years' work. These are extremely tedious, low throughput studies. This is the most throughput because we just tested them. A lot of times these experiments, you get 1 neuron per experiment, right? It's very tedious. So it's precious data. These were all done. I did a time course of this that I didn't put in here. With the inflammation, it started at about 2 days. It peaked at 6 to 7 days, and then it petered out after a couple weeks.
So you do a transient application of vinblastine?
Well, no, this is all with nerve inflammation. The vinblastine, and I saw, you gotta talk to me, I saw your ad for a postdoc. The vinblastine application is, yeah, I need a job. The vinblastine application causes this within 2 days, and after 6 days, I'm gonna show you this, the axonal transport seems to be back to normal. I have up on my board when I was preparing for this that I have to do a time course of, I'll show you in a minute, kinesin transport altered by nerve inflammation and the axonal transport, and I'm least interested in the axonal and of the vinblastine. I'm least interested in that.
You know why I'm asking those?
Yeah, I do.
Like,
Go ahead.
You block the transport, but you're only blocking. So the idea is there's a constant flux of stuff going back to the cell body, right?
No, going down to the periphery.
The other way.
Yeah.
Okay.
But I'm getting to this.
All right. Yeah.
So this is showing that, and this we did mostly at 6 or 7 days. So the concept is that it's allowing the mechanosensitive channel to slow down and then become expressed and functional on the axonal membranes in places where they're not normally functional or they're not expressed. But the problem with that, and this is kind of a holy grail of the pain field, is that no one knows what the mechanosensitive channel is in a nociceptor. It's kind of something we all want to know. So backing up here just a second. So we wanted to know, we looked, and I had a grant, I spent a year, maybe closer to 2 people years, putting every antibody, every candidate antibody to every candidate mechanosensitive channel that I could, mostly potassium, sodium channels that were available, and nothing showed a buildup. So I had to switch gears a little bit, and I designed an experiment. We know that it'll build up if you tie it off, because it can't go anywhere. And we also know that kinesin is the major transport motor, it's called, for fast axonal transport. And we had enough evidence to know that the mechanosensitive channel is likely going that way. So kinesin is usually depicted in the journals as something like this, sitting on microtubules and going down the axons like this, and then dropping them off at the other end. So they're carrying a lot of things. So we ligated it, and we wanted this to happen, which does. And then the hypothesis was that if we inflamed it or put vinblastine in, there'd be less buildup here, and it wouldn't have buildup there because that has through conduction. We didn't bother with that because that's obvious. We stopped looking at the normal side of that nerve, which is like a control for that nerve. But also, when you cut half a nerve and you get data from that, it's a lot less traumatic for an animal than going like this until you kill it. So anyway, here's the data from this, which we published in 2003. After 2 days in a control, it builds up a little bit, but it's a dramatic buildup after 6 days. And that's as far as we've done. And this is just control, nothing. And with the Freund's adjuvant neuritis, you can see that it will build up less, but it builds up clearly less at 6 days. These are the data, this is the figure. I didn't quantify or anything because you can see it. And then you can see in the vinblastine, there's no buildup compared to that. Now we have a method for quantifying it, and I'm going to do that. But we have, if you can see it, I don't think you should have to quantify it. And that's pretty obvious that the vinblastine has come back. Okay? So the future, we have a way, and I'll show you how we're quantifying that if I get to it. So this is showing that axonal transport restriction. The problem with this from the previous paper, it really shows up nicely over there, from the previous paper is that we said that reducing that vinblastine A causes axonal mechanical sensitivity B. We know that vinblastine application A causes reduced axonal transport, but what we couldn't do, and this is a classic syllogism, we implied that or stated it, is that the mechanical sensitivity was linked to the reduced axonal transport. Because now we know that we know that endoplasmic reticulum can be producing these channels. It could have done something to that. We don't know the channel is, so we don't know what's producing it. If it's being produced locally, it could be from from mitochondrial poisoning. That's what Gary Bennett thinks of the chemotherapeutic agents. Well, he's published a whole bunch of papers on that, so I guess that's why he thinks that. It's damaging the energy source there. But we had this buildup, not a deficit, and they became mechanically sensitive. So this is actually more evidence that it is impeding the channels, and this was published with a whole bunch of behavioral data as well on the vinblastine model. So why is this important? It's important because the tests that are used, like this, is a ubiquitous test called a straight leg raise test or Lassaig's test. There's a lot of modifications, but everybody with back pain and radiating pain will receive this test from a primary care doctor, especially a neurologist, and hopefully pain specialists and neurologists. It's just done a lot. The stimulus in this is actually in the basic part. The stimulus is in the posterior hip. So the nerve, it's going wavy through the tissue. It gets stretched out a little bit. It gets elongated till it builds up enough tension to start stretching a little bit. And then after it kind of reaches, or at the same time it's being stretched, it starts moving distally. So in this test, once you get over about 20 degrees here, that nerve is already starting to migrate. And I can show you with an ultrasound really clearly how the nerves move like earthworms in a tube, sliding them in and back, or flossing, which I really like talking to about the dentist. I say, well, we floss nerves. And so here the stimulus is there, but the symptom that you're trying to reproduce is often, and that's a classic L5 pattern, or is on the back of the calf or in the back of the calf. And this term dysesthetic pain, I believe, was coined by Ian's postdoctoral fellow advisor, Howard Fields. Just saying. Props to Howard. And these tests have been designed and are used more and more frequently now, like for the major nerves, all the major nerves up and down. There's only about 6 tests that we can do. But when the nerve system is connected, and when you go like this and bend your head forward, you move your spinal cord, you move your cervical spinal cord, it goes over to the side of the straight leg raise test. I mean, there's a lot going on. But we don't really know how to differentiate what's going on yet, which is a problem with the clinical tests. So here's a direct patient relevance. This woman had fallen from a height and hit on a railing in her mid-sciatic, mid-thigh region and hurt, and she had chronic pain, like horrendous pain, in a walker, and she had been getting treatments like intrathecal narcotics. She had been on everything. I saw her in the pain clinic. They had me come in to show them how to use an interferential current machine. So I was kind of insulted they asked me to do that, because like you turn it on, you turn the knobs, it's like a TENS machine. So I asked them if I could touch them, because touch the patient, because I'm not there as I don't have hospital privileges there. They had no way to do that because they do now with chiropractors. But her straight leg raise test was positive at about 10 degrees, horrendous pain, and more than that, I could drop it down a little to get out, and there's ways, like for the med students, if I go like that, what nerve am I pulling on? New name, not old name. Oh, come on. That's going to be the fibular nerve, and that's going to focus more on the tibial nerve. So hers was mostly perineal nerve related, and in fact, with those tests, you can see different parts of the nerve move when you do ultrasound here. So anyway, this is one of the first and best MRIs done, which is a story in itself from the guy who wrote the book on MRI, actually. This is a normal, you're looking up the legs, like you're looking up, so this is the left side. That's a normal sciatic nerve. I keep pointing at it. That's a normal sciatic nerve, and you can see the fasciculation and some fat around it. And this is the base of the gluteus maximus, because you can tell that because of the coarse nature. And if you look in comparison at this nerve, where it was damaged, it's almost just blended in with the muscle and the fascia. So this was tethered, and she had a horrible time. And I won't go into her mostly failed treatment, because once you get the fascia scarred up, she probably had a lot of scar tissue inside the nerve. That's basically the end of it. I think manual therapy would prevent that. Don't tell anybody. Okay, so that explains mechanically provoked radiating pain. That is the basis for mechanically evoked radiating pain in the absence of nerve injury. Now, what about the pain that people have, like Cheryl had, just sitting there, not in pain? And by the way, her problem was almost certainly secondary to the torsion, which affected her sacroiliac joint, which was probably inflamed. It was inflaming the sciatic nerve because the whole lumbosacral plexus crosses right over the top of the anterior capsule of the sacroiliac joint.
Well, actually, when it occurred, I was actually completely normal. I was working in clinical skills, came up from a seated position to stand, and immediately was different.
That is unexplained, and when people get treated and they get immediate response to spinal manipulation, that is unexplained. This is one in Canada. I was on his PhD
I had
committee.
a number of different treatments, and they couldn't locate it with the lumbar disc or sciatic area, but it was coming from the sacral area, but not where the piriformis was, and it was coming. That's so
Piriformis has been very stylish for 15
and it
years.
was like everybody else in here, and then the next minute I couldn't walk.
Well, there's a lot of I always feel like when something like this comes up, it deserves a lot of attention. Nerves get tethered like this woman's nerve, right? She could have no symptoms until you did some small thing that yanked on it, maybe. So, you might have been preset from other things to have this problem, then just have it. You can run like, if this is the level of where you're going to develop symptoms from bad inputs into your system, you might be right below that, and you might have a psychological trauma because your body can't tell the difference, might throw you into a physical pain state. And this is a good way to look at it because it also is maybe why multimodal approaches work better. You can knock the building blocks out of a pain case, and it might not matter which one you knock out. It might reduce them below the threshold for their pain problem. And that's a nice philosophy that I always use to help people, I thought. Made me feel better anyway. So anyway, that doesn't explain, the mechanical stuff doesn't explain ongoing pain, which would imply that there was in people that have the radiating pain and they have the mechanical, it would imply that they had chemical sensitivity. And Roseanne's been working on this project for a little over a year. And the main results are the same model with vinblastine or Freund's adjuvant, so I shouldn't have neuritis. And this is a typical recording showing unitary, and this is in a paper that we just submitted. This is stimulation of a receptive field. That's stimulation of a nerve. She always knew that they were intact, and they had limited to deep because they're the only ones that develop the mechanical sensitivity. This is a normal response of inflammatory soup, which is bradykinin, histamine, serotonin, and a prostaglandin. I can't remember if we used PGE 1 or 2, and it frankly doesn't matter, all at 10 to the minus fifth. And if this is injected on yourself, I'm happy to do that. I've done it, and you can tell that it hurts, but we don't know which component. Bradykinin usually just causes itch, I think. Anyway, this is an injection into the nerve of a naive animal. So this is into its receptive field. This is right into the nerve. That's where the median nerve and the ulnar nerve are, by the way. But that's the same to me as the sciatic nerve. And it's up here instead of down here. So no response, and there was never responses normally. This is into the Freund's adjuvant. Here's the injection. This is a response into a Freund's adjuvant treated nerve after 5 or 6 days. And this is an injection into a vinblastine treated nerve after 2 or 3 days. And you can see a flurry that basically looks just like this. So this is chemical sensitivity of the inflamed nerves, which are subjected to an inflammatory milieu, but they're not directly, like that milieu, by the way, the macrophages and the T cells and that are recruited to that inflammatory area don't penetrate the nerve ever, really. And we have a paper in my colleague's favorite journal, Journal of Neuroimmunology. Well, when you put a bunch of goo on there, it's hard to tell. It kind of fuses in with the goo. The vinblastine doesn't recruit any immune cells, but it still develops this. So it's something independent of inflammation is the point. And it might just be this axonal transport. Another thing is that on a time course out to 3 months, there's tons of immune cells still around the nerve with the Freund's adjuvant, but the mechanical sensitivity is long gone. So we haven't found what parallels. That's why I need to do the kinesin study with the axonal transport. Okay, so to get more evidence for the receptor hypothesis, we looked at we had a nice robust response with histamine H3 receptor antibody, and you can see better over here that this is in that ligation model. You can see there's more signal here. And when we did in a normal animal, and when she did this same analysis, and this was quantified, we measured from here to here 500 microns out from the suture site. You can see visually that there's less signal, and we quantified that, and you can see this didn't hit significance. All combined, it was meaningful, and in these groups it was significant. So this is again supporting the axonal transport as the mechanism of where the histamine H3, they also are thought to go by fast axonal transport. I also did a long time ago, and this was a break in the funding of this, this didn't lead to it, but I had a break in the funding. This is the same model except with vinblastine, then taken ex vivo. So I wanted to be able to use knockout mice and figure out what the receptors really were, going fishing. And you see a same response. There was a good response to break the inflammatory soup, but also to other components in the inflammatory milieu, like a low pH and ATP placed on the site right here where it was treated. And why is this important? Well, it parallels with ongoing pain. So what's the evidence physiologically for activity, just activity while we're recording? Well, there's a problem with doing it during neuritis because there's a problem doing this in general because we have to beat up the receptive field so hard that it sensitizes the receptive field. So in this model, recording from the dorsal root, there's almost always ongoing activity, even in the control animals. And in this, there was ongoing activity when we cut L4 and recorded through L5. When that happens, you get a diffuse transient inflammation all along the nerve as the L4-related neurons degenerate, which takes more than a week. But instead, I did a different model where I recorded from the sural nerve with the inflammation here. And I found that over time, there was an increase in the proportion with ongoing activity. And that's a small data set, relatively speaking. But I found that the rate decreased. And I don't know what that means because this was still at a rate that was above what would be considered, right around what you'd consider a sensory perception threshold, which was found to be around 0.5 hertz, which is right over here. And that never occurs. We don't get any ongoing activity with vinblastine treatment. So this is related to the inflammation. And this is and I only have one more slide anyway. So this is the summary of the work up to date. I didn't mean to do that, but I was drawing this out for Michael Shacklock, who goes around the world teaching neurodynamic stuff, and so he likes my science. And he was here last year to a unbelievably packed seminar in Portland with he's like a god to physical therapy, or a guru for physical therapists worldwide. So this is basically what I drew out for him, which is the fast neurons that are light touch mostly, and the fast sensory neurons for position sense and light touch. Nothing happens to them at all except they normally have ongoing activity. You should hear a muscle spindle. You can't get them to shut up. I stimulate the daylights out of them to get them to shut up because they interfere with the recordings. And this is from the skin. We think we have ongoing activity. That's been one experiment. We don't know anything about their chemical sensitivity yet. The deep neurons, we've shown robust ongoing activity and mechanical sensitivity with the vinblastine as well, the mechanical sensitivity. We have no idea about the chemical sensitivity except, well, we now have done this, so we just put that in. And this is what Cheryl was mentioning. This is the only data that, well, there's a lot of reflex data from somatoautonomic and for somatoautonomic reflex control of the homeostasis of an internal organ. And this was from inflaming a nerve, and I was recording from sympathetic neurons, and that's a whole separate talk, but there was a decreased ongoing activity. They always have ongoing activity. There was a pretty clear decrease of ongoing activity during inflammation, but there was no mechanical sensitivity on those axons. But I'd like to talk about that sometime to the clinical class, and this again was this. So anyway, I was going to do a clinical demonstration using someone or her. The tests were with with Stacy Teamy, who, if you don't know, she's one of our clinicians, osteopathic clinicians with a full-time manual therapy practice, or not full-time, in Brunswick, Topsom. And you don't mind me saying this, right? No. Okay, so she had some symptoms in her arm, and I checked her out a couple days ago. And the tests that we do, which are stretch the median nerve, stretch the radial nerve, stretch the ulnar nerve, they actually were all negative. So I went to the palpation, and she has an acromioclavicular restriction and a capsular fibrosis in her, the best we could tell. And it was pretty obvious. So they were good in ruling out the nerve problems, which was good too. So anyway, some of the challenges we have are that we don't know the mechanism of the axonal sensitivity development. We don't know the mechanical transducer. We don't know how well these tests integrate, even though they're mostly done clinically. We don't know, they're not incorporated typically into medical practices to get the diagnostic accuracy and inform the patient care is what we want. There's not much research with the sensitivity, or especially the tension distribution. And this I'm mentioning because last week Frank Daly and I just started a new project where we want to implant force load transducers or tension transducers all along the path of the nerves and do these tests and see if there's any way to do the test to focus on one area. Although pretty much most of the people with radiating arm symptoms in their arm, you just poke right there and you reproduce it. It's like people with carpal tunnel syndrome, you go right there, yeah. So, but still, we took one of the cadaver's arms, which not showing you a picture because it's particularly gruesome because it's one of the Teal methods, which are just floppy and flaccid, and it was cut here, and we tied the median nerve off to a force transducer, and I implanted one that I just bought in the on the ulnar and the median nerve here, and we went through the test, and it was a little, it's the first time we did it last week, and we got these different Newton loads, the loads here from the arm and the forearm, from the median nerve and the arm. So we're going to do it a few more times, and hopefully we'll get some kind of funding to continue these. And last, I usually finish 15 minutes ahead of time for questions. I'm sorry about that. The acknowledgement, this is Jean-Gil Lim. He's a professor still. He was a professor and came through Harvard Medical International into my lab, which was wonderful because they paid for everything. I mean, his university paid for everything, his transportation, his benefits, his salary. It was great. So he did a lot of the initial mechanosensory axonal mechanical sensitivity experiments. We did have a language problem, which led to me, like I said, tossing out a lot of the data because I couldn't understand what was going on. This is a lovely photo of Andrew Dilley, who's a professor, well, senior lecturer. That's somewhere around the associate to full professor level in University of Sussex in Brighton. This was taken at Goose Rocks Beach a few years ago, and it's way better than his profile picture online. And this is Roseanne Gouveia, who's currently in the lab and just done all the experiments for the chemical sensitivity. And then we have to acknowledge the funding, of course, and I've been fortunate to have a lot of different, maybe they get sick of me and I have to go to a different institute. But there's 5 different institutes with a few different grants here, and I had some significant funding from the Samueli Institute, which is a primarily alternative medicine. They wanted this homeostatic stuff done, which I failed to get funding for. And the University of New England has been quite generous in the last couple of years with some funding to help with the, get me kind of rebooted in the neurobiology field. And then thank you, and I'm happy, I know it's 1, but I'm happy to answer any questions. It doesn't look like anybody's coming in. Amy? Mike?
What is it about slowing axonal transport that you think allows the insertion of new receptors in the membrane?
Channel trafficking. I don't think that we have the type of mind to study that. I think we'd have to be theoretical physics or chemists. I look at some of the papers and they start having formulas for how, it's not well known how a channel is transported and then expressed on its receptive field. Or at least I can't understand it. And it could be as simple, I mean, we talk about vesicles going down, like with CGRP and substance P, for instance, they're co-localized in secretory vesicles, and they go down, they're packaged, and they go into the cell wall, and they go like that, and then they get released. But how channels get incorporated, that's something I've always wanted to do, is electron microscopy of these channels coupled with immunohistochemistry to see whether the channels become externalized. But I don't know how else to do it, and I don't know the mechanism at all. But I think what we're doing with the slow axonal transport is reproducing what happens at the end, because it slows down because it can't go anywhere. And that's why I started doing the ligation. But the mechanism, no clue. Do you have?
No.
Okay. Jeff?
I have a follow-up to that question. I was wondering the same thing, and I'm not real familiar with literature about how ligation might lead to kind of precocious externalization of these vesicles. But I think quite a lot is known about how those vesicles are trafficked to their target areas on an axon, for example, and there may be even some useful tools for you. I'm thinking of botulinum toxin that can interfere with secretory, with transmitter vesicle release. Maybe there's something there that you could use in your experimental paradigm to block that fusion of a vesicle with the axonal membrane and then block your hypersensitivity.
Oh, I'm sure there is, and thank you, and I'd love to hear it. When you have limited amount of there's a key factor in doing all that. It's called dollars. And so, like I was asked, and I had some potential funding in the beginning to see whether Botox would alleviate nociceptor activity, and that's been since done, I believe, and not in terms of kind of referred pain or in terms of preventing migraine from what's a whole separate mechanism probably, but I didn't have the time to do it then, and I don't have the money to do it now. And so these projects have been basically stalled out since this decade started, which is really, I find really unfortunate, because they have potential, especially since I can do these recordings and knock out mice now. So if you can help with that, I am really happy to collaborate with it, of course. But I agree, I just don't know enough about the mechanisms myself. Anything else?
One thing I keep thinking about is that in a nerve there's not just axons. You've got
Right,
lots
it's
of-
only half axons.
You've got loads of other cells, Schwann cells, satellite cells, and then you've got a membrane around the nerve, similar to a blood-brain barrier, right?
Well, yeah. Well, actually, there's a blood-nerve barrier in the vessels that penetrate all through it, and there's the perineurium, which is like a skin around it.
So are you suggesting that the muscle is releasing maybe some inflammatory factors that is then getting into the nerve?
Yeah.
So it's not just...
Well, or something is causing the only thing we know in common between these models is reduced axonal transport. Mostly. The inflammation causes ongoing activity, which is what you want developmentally. And in fact, I'm just embarking on a new project with Terry Walters, who's a professor at University of Texas, Houston, where we're going to be studying persistent ongoing activity far beyond what most of these studies are, the time scale, like at 2, 4, 8 weeks. But we're using his concepts, we were just talking about this, Tamara's involved with this as well, a combination of inflammatory and nerve lesions. And he believes it takes both to end up with persistent ongoing discharge that's originating from the dorsal ganglion soma. And he's got a ton of data from spinal cord injury. We collected preliminary data in my lab last month and the month before that showed, and the model was I inflamed the sciatic nerve here, and then in a remote area, I went down here and I denervated the lateral compartment and some of the skin here, but they weren't getting inflamed. That was just a clean snip of the fibular nerve. And after 2 weeks, there was a lot of ongoing activity that we proved by cutting and anesthetizing the nerve was coming from the dorsal root ganglion soma.
And I've got a one-track mind with that as well. So
Don't let it keep you up tonight.
I always think that the soma is going to respond with a transcriptional program, and that will give you some clue as to what the factors are.
Tamara was revealing her knowledge of that yesterday.
What?
How when you have the nerve injury, there's a lot of transcriptional differences in the soma of the ganglion. One of the more sensitive ones seems to be ATF3 production, which has been shown in the neuritis model to occur. There's been a lot more here that I want to make it as clinically relevant as possible. But thank you for the questions. And thank you, everybody.